congratulations, and thank you so much for the kind invite. This was the last slide of my previous visit at Kozhikode, and it was an amazing, as Sujit was mentioning, it's a wonderful city, and definitely we all also are missing our physical presence there. That was on lamellar keratoplasty, and this time he said that I need to talk on corneal restorations. So that's fine. So what I'm going to do here is that I'll just share our experiences. What do we generally do when a tear repair comes? And I'm going to focus on the practical aspects and how do we generally do here in Ambala. So we as a cornea surgeon, as general ophthalmologist, we keep seeing corneal tears and laceration. And I think for an ophthalmologist, it's mandatory that you know how to repair tear, because it can be life-saving and it doesn't need much of the skills. It's just that, if you're an ophthalmologist, you can definitely repair these kind of lacerations. So I have divided my talk into 3 parts. So suppose a patient of corneal tear comes to you. So what do you do before the patient? You take the patient into OR. What do you do in OR? And what do you do once the patient is gone out of the OT? In OT as well, what you will do there, I have subdivided into 2 parts. Before picking up your needle or, doing all those needle things, what do you do, and how you perform your suturing in these cases. So let's go one by one. So patient has come in the OPD. What do? You have not taken the patient into OR yet. First and foremost would be evaluate as much as possible. So sometimes patient sits on a on a slit lamp and patient can't open their eyes. Sometimes they squeeze, so you can't do much. You need to just ensure on slit lamp that the globe is intact or not. Is there a perforation? If possible, if you can make out which is a full thickness perforation or lamellar perforation. So evaluation should be as much as possible. That's there, but you don't need to be aggressive. You can keep something for evaluation in the OT under the microscope. Any full thickness perforation needs repair, no doubt about that. You don't that is a full thickness, I'll put a bandage contact lens, I'll do this, that. No. Any full thickness perforation should be repaired. Lamellar laceration, depending upon how it is, may be exempted. Another important thing is you just document what is the visual acuity, and if possible, do a gentle B scan. Again, this is not mandatory, and if you want to do a B scan, should be very gentle. Basic aim is because you need to understand what is the injury, what was the injury pattern. You need to spend some time with the patient, with the relatives. Sometimes, in your OPD, there'll be with the one patient, there'll be 9 or 10 people because of trauma. So you need to understand how you take a feel, how these people are, whether to follow up and do it nicely, that you have to document, and gentle B scan to see if there is any foreign body inside, so that you can explain what is the prognosis. Extremely important, more important than doing the suturing per se, proper counseling and the consent. You need to tell patient that, okay, this is just a repair. We are going to see what is there in the backside of the eye, what is there in the retina later on, and if needed, and it is not for the vision we are doing at the moment. We are doing just a repair, a primary repair. That should be very clear, because we see, suppose a patient who had repaired elsewhere comes to you after 1 year, 2 years, somewhere else. You ask him, okay, what has happened? So he'll start from, oh, I had a surgery there, and because of the surgery, my eye became like that. So it is important we tell them that, see, it is an injury which is serious stuff, and we are just doing a repair, and later on you might need multiple surgeries, might need 1, 2, 3 surgeries. We are not sure how the prognosis, that thing should be very well counseled to the patient as well as to all the relatives. Better to make them all sit there and explain what it is. So once this thing is done, evaluation is done, there's a perforation, there's a full thickness, you have ruled out a foreign body, or planned whatever you want to do. Then if you have decided that surgery is to be done and patient is ready, post for the surgery as early as possible. Don't delay, as early as possible, and then decide whether you want to do a general anesthesia or local anesthesia. So what we generally follow is, if there is a limbal to limbal tear, big tear, better to do under general anesthesia. But again, if the patient is cooperative, you can do under local anesthesia as well. In LA, you need to give some good retrovalvular anesthesia. It ensures that you don't give too much of block, otherwise it will increase the pressure, and the iris which is inside may come out, lens matter may come out. So you need to be careful. If you have a doubt, please take a decision in favor of general anesthesia. Of course, the patient is not cooperative, like children, you have to take it under general anesthesia. If the patient, suppose that you are seeing the patient now in the morning and you have planned surgery after 2 years, 2 hours, 3 hours, or if you have seen in the evening, somehow you have to do the surgery next morning, shield it, don't patch it. No pressure patching, only shield. No topical medications, but give systemic antibiotics, and if needed, tetanus toxoids. So this is what you are going to do before you take the patient into OR. So now the patient has come into OT. It has been, given the whatever anesthesia you want, and very gentle drape has been applied. Now what you will do? So before you pick up the needle, you need to do two things. What are those two things that you need to do? Evaluate and wash. Evaluate, why? Because as I said, in slit lamp, sometimes you are not sure what is the extent of tear. So sometimes it looks like that the limbus is not involved, but when you evaluate, it looks like that the actual limbus is involved. So evaluation is extremely important to see what is the extent of wound and what is the type of wound. Is there is anything else? All those things you need to evaluate. So before you pick up your needle, please spend some time and see what kind of wound it is, whether it's a perpendicular wound or it's a shelved wound, whether the wound has an apex or it doesn't have any apex, whether limbus is involved or limbus is spared. How's the status of intraocular stuff, whether there's an iris prolapse, there's a anterior capsule rupture, if there's a vitreous, all those things you need to evaluate first. So perpendicular or shelved, if there is something like there's an entry wound and an exit wound is at 90 degrees, so it's a perpendicular wound. Shelved is it's an angle. Why we need to know about this is when we are suturing, sequence of suturing will depend on what kind of wound it is. So if it is a perpendicular wound, that generally needs repair first. So first suture generally goes at a area where it is a perpendicular wound. So these kind of wounds, so it is possible, so one area is perpendicular, one area is shelved. So just see, evaluate what kind of wound it is. And then next is whether that tear, that laceration has an apex or not. Apex means, sometimes you have this. So this has an apex, all this pointed. So this also has an apex, although, just 1 minute. Okay. So although it's curved, but still it has an apex. Here it is a zigzag, but still it has one apex here, one apex here. This doesn't have any apex. It's just a kind of linear kind of laceration. So you need to see what it is, because sequence of suturing will depend on this. We'll cover later on. So next would be, you can see this tear, this laceration, this has an apex. So I can see the apex here. So I know that this laceration has an apex. Whether limbus is involved or spared, very important, because if the limbus is spared or limbus has teared, so you need to focus on that area first. Again, that will come. So you need to document, or you need to see whether the limbus is involved or not, or sometimes it is one limbus to other limbus, sometimes one part of the limbus only. So that will depend which suture you are going to take first. Next would be, as I said, whether the iris is prolapsed. So how old is the tear? How old is the laceration? Suppose 2 days, 3 days, you might plan to excise this iris, or suppose it's fresh, you might plan to reposit the iris back. Then if it's a cataract, so preferably in primary sitting, so we don't do any cataract surgery or any other surgeries or IOL. Preferably in primary, just do the primary repair. You can do the cataract surgery even if it's a child or it's a phacolytic kind of thing. You can take it after maybe a 1 week, 2 week also. So preferably, as far as possible, do plan any other surgery later on, although any other loose lens matter that you can plan to remove in this setting itself. Again, if there's a vitreous, you need to plan that you need to do some vitrectomy in the wound, so you need to free your wound from the vitreous down there. So this is what you are going to do, evaluation before picking up the needle, what kind of wound it is and what are the other things that are involved. Next is wash. Again, wash is very important. Our aim is to clear the wound margins. There can be dust, you can't leave it, it may cause infection. There can be a foreign body there itself, need to remove it. There can be iris, so you need to plan whether you need to remove the iris or you need to deposit the iris, and then there can be membranes, there can be fibrins, so you don't want to leave the membrane there. You need to free these wound margins. So wash is very important. Spend some time to do a good quality wash of the margins. Again, iris, you don't want to suture the iris in the wound, because if you see one sympathetic case, you will remember it throughout your life. So you cannot afford to leave iris in the wound. So in short, the wound margins are clear. So once you see what kind of wound it is, then you wash it and ensure that your wound margins are free. Now you are going to do your needle work. So while you're doing your needle work or you're doing suturing, what is the basic aim? Basic aim is to restore the anatomy, restore the dome of the cornea, restore that the kind of cornea it is. The anatomical landmarks are well opposed. And very important is the wound needs to be at the end watertight wound and minimum possible astigmatism. I've done it with red because you cannot leave a wound which is leaky. Even if you need to do some of the other way, you have to ensure that it is a watertight at the end of the surgery. You need, so what we generally do is we use 10 nylon. It's important there's a cutting needle, a spatulated needle, so that it can give, because the edematous cornea, edematous stuff. So it is important that you don't have to, take multiple sutures in one go. The suture should come. Again, very important. Each laceration is different, and we need to customize repair pattern as per the laceration. So it's not that just one thumb rule can apply to any laceration, although the basic principles remain same. So once that patient in the OR, at that time you might think of taking one suture before, one suture later. It's absolutely fine, but the basic principles remain more or less same. So what are those principles? So when we when we do a penetrating keratoplasty, we generally follow ALTR. ALTR is apposition, length, tension, and radiality. So those all that ALTR gets, we can apply on your corneal laceration repair as well. What do you mean by apposition? So apposition is anterior surface to anterior surface apposition should be very good. That is our principle. Because if there is a overriding or gaping, there'll be some epithelial defect, that you can have Dellen, you can have the weird kind of astigmatism. So anterior to anterior apposition is very important. That is our aim. Length should be the equidistant. So if okay, so if there's a tear, so from the laceration, I don't know if I can move the cursor. Okay, it need to be equidistant from laceration, but equidistant from the posterior margin. So if it's a shelved incision, from the most posterior margin, it should be equal. And then next would be tension. As you can see, there should be no gaping in the lower half. Here, I can't show you the cursor, unfortunately. Okay, so in the lower half, the last photograph, you can see, although on the surface, it will look like it is unequal distance from the wound, but actually from the posterior margin, it is almost equidistant. Because if we do it from the anterior margin, there can be an overriding or gaping. So it is important that the length is equidistant, but from where? From the posterior margin, the exit wound of that particular whole laceration. Tension, you need to keep the suture slightly tight, because these are edematous. Suppose there's a 500 micron cornea, this has become 1000 or maybe 1500. So once you have taken the suture, that 1000 micron is going to become again 550 microns. So what will happen? The suture will get loose. So it is important to keep suture slightly tight. Overall, tighter in the periphery and optimum in the center. But again, you cannot keep the suture loose. It has to be on a tighter side. Radiality again, you need to be perpendicular from at the area where you're in the line of the laceration. So you can see, so these sutures will not be parallel to each other. They will be perpendicular at an area where this laceration is, as you can see in these. So these are not parallel sutures, but what I'm doing is just at that point, there will be a right angle. You can take a right angle, and in that area, you need to be perpendicular. So, so this is what are the basic principles: the apposition, length, tension, and radiality that you need to keep in mind while you are operating. What will be the sequence of suturing? So this will again depend what kind of wound it is. If it's a perpendicular wound, that part of the area will be sutured first. So one part, suppose, is perpendicular, one part is shelved. So you are going to take first suture in the area where there's a perpendicular cut. So for example, in the center, if this is a perpendicular, so you will take this suture first, and in the below, if this is shelved, you will take this suture later. The apex will be sutured first. So first suture will be at apex, and next will be on the margins, the edges. And then this one half will be divided, you can see, into two. And if needed, if you feel that there is a leak or there's still gap, you can put more sutures in between two. So you have to take first suture at the apex where you have an apex. So if you have more than apex, one or two apex, you can see this will become a stellate kind of wound. So here you can use a mattress suture also, or bursting suture also. I have never taken in all these 15, 20 years. I've never done this bursting or, mattress suture, but this is there and this can definitely be used. These stellate wounds, these kind of wounds, these are really challenging. And sometimes any kind of suture, it is difficult, and you might need to use some glue or cyanocolate glue as well. Again, you need to ensure these kind of wounds, whether there's a tissue loss or not. So any tissue loss is very difficult to suture. So that also you can see whenever you are having difficulty, just check that if there is any tissue loss as well. So next is perpendicular shelf we have discussed, apex we have discussed. Suppose a linear laceration. So first suture would be on the edges, and then it will be divided into two, and then each half will be again divided into two. That's how we are going to do it. So I'll show you a quick video. Again, first is wash, as I said, ensure that all the dust, membrane, everything is taken care of. You can see this is a shelved kind of incision. And again, when you do the eyes, this is difficult. So I just will highlight this again. So when you do a AC tap or you do a MVR, so it is important to give a counter traction as well. So here, so I'm trying to use no touch technique, means I'll not try to touch the wound. Here you can see it looks like that it is unequal. So if this is the wound, so this is small and this is large, but it is not like that because the shelved incision, so inside the posterior margin is somewhere here. So it is equidistant from this point. So that is something which we need to understand, that how we are taking the equidistant sutures. And this is, as I said, the apex will be sutured first, then the edges on both sides. Again, as far as possible, no touch technique. Try to keep as long as sutures. The longer suture will have more compression zones. You'll need less sutures. And this will be perpendicular to this area. So if this is a line, this will be perpendicular to this. So here it will be perpendicular to this. Here it will be perpendicular to this. So perpendicular, go at 90% depth. Don't be superficial. It should be 90% depth on the both sides. And then, try to bury the knots away from the pupil. And then once you have done it, see if there is any leak. If there is any leak, don't hesitate in putting up another suture wherever there is a leak. As I said, you have to take a decision on table. And then as you can see, I was seeing some leakage here. So I'm taking two more sutures in these areas. Sometimes you take one suture and you see the previous suture has become loose. In this case, the first suture, it became loose. It's absolutely fine. Go ahead, remove it and take another suture, and then bury the knots and place a bandage contact lens if you want. I like it because it makes the patient comfortable. So this is how a wound which has an apex is sutured. Next important thing is if the limbus is involved or not. If limbus is involved, limbus should be sutured first. The first suture will be at the limbus, and it will be a pretty long and tight suture. Then will be then at the edge, then again same, divide into two, and then again divide into two, and you finish it off. In the periphery, larger, more tighter sutures. When you are coming toward the center, maybe a slightly smaller size. So here again, you can see there was a limbus tear. So I can see there is a tear in the limbus. So this is broken. So first suture will be at the limbus. I have not even, seen this. I'm not trying to reposit this iris or anything. I'm just securing the limbus first. Sometimes two parts of the limbus are, 2, 3, or even 4 mm away. So you take suture in one end and then take suture in another end. Ensure you have made this anatomy of limbus perfect. This will be the first suture that you take. So now I'm seeing where it is. So I'm just trying to separate all the membranes, and because it was a fresh wound, I'm trying to deposit the iris back. And here I can see here there is a limbus in this area is also involved. So again, so next suture will be again at the limbus, the other opposite side of the limbus. So this again will be so this is, as much as possible, we should avoid this. But sometimes, as I said, it is not possible. So ensure that your suture, first suture, the limbus is well spared. This will be very tight. You can see it is very tight. So once these are tight, then you go ahead and make these all perpendicular. Same concept. Then larger, preferably go from the non-edematous area. Here you can see this will be perpendicular to this part. So it will not be parallel to the other suture. It will be perpendicular to where the incision is. So I'll just fast forward it. Again, this is a small apex. I'm suturing this apex. I'm suturing this apex, and then in between we will now since there is some part is restored, I'm placing a viscoelastic from the side port, ensuring that there is no part of iris is in the wound. So you can see here both from up and below, both I'm just ensuring that there is no part of the iris is left over. And then same concepts, and sometimes you can see there is a wound here also, there's a tear here also. So that also you need to repair. This will become a Y kind of incision in this area. So again, in case you feel later on there is some leak, you can always place some bandage, contact lens and some glue. In this patient, I think we had used some glue here in this area. So again, as I've already explained about the intraocular thing, that these things will be taken care of later. If there's a vitreous, go ahead and do the vitrectomy. So now we know in the OT, before picking up the needle, you need to evaluate, need to wash, and while doing the suturing, what are the ALTR and what are the sequence of suturing. So once suturing, everything is done, visco wash is done, patient is out. What do you do after OT? Systemic antibiotics, post-op topical steroids, cycloplegic, and B scan on first post-operatively. It should be must, because you need to document if how the vitreous, is there any verticose, any foreign body or anything, and then you explain further, and you plan whatever you want to do, a cataract surgery, you want to do anything. And these sutures, they tend to get loose. Watch for them and ensure that any loose suture should be removed. If you are removing within 1 month, replace it, otherwise you can remove it. Routine suture removal would be around 3 months. In children, they tend to get they heal early, so you can plan a slightly early suture removal as well. So I have just repeated this slide because each laceration is different and you need to customize it. But just remember the basic principles, how we are going to oppose these two margins and what are the sequence of suture that we are going to use. So I hope that I could do some justice to this, but this I'm open to any other suggestion, because this is what we generally do here. So I acknowledge our department, especially Vishwa, Yatri. We did a class day before yesterday.